Hi everyone. So today I would like to discuss the communication of unexpected news after an ultrasound. Everything that we would discuss today in this webinar is based on the UK guidelines of discussing unexpected news. And I will give you some links at the end of the presentation so you can go read these yourself. And we'll be discussing a few things in terms of what to say, what not to say. So let's get started. So first you would start by getting the patient's history. Now, most of us would start by getting the first day of their last period. I often like to ask if this was an IVF pregnancy or a natural pregnancy. And what I like to say is, do you have any concerns that you would like to share with me before we start the scan? Now, if they do share sensitive information with you, please thank them for sharing this. So what they have suggested we say here, so anything that's blue here is a direct quote from the UK guidelines of communicating unexpected news. So this is what they've said here. Thanks for sharing that with me. It helps me to be aware of your experience before I start scanning. So here you're acknowledging what they've told you, and you're doing this before you even start the scan. What else can we do to acknowledge what they've said? If they tell you that they're anxious, please acknowledge that they're anxious. You do not want to just start putting information, go about your scan, and be robotic in your manner. So observe their body language. What you can say is, I can see that you are anxious. I will let you know the results of the exam as soon as I can. So this way you're mentally preparing them, and you're also reassuring them that you can see that they really are anxious. You're not ignoring them. So here are suggestions, some suggestions for how to mentally prepare them for what to expect. Here's what you can say. To begin, I will just have my own screen on. However, once I've finished my initial assessment, I can switch the other screen on so you can see the scan images too. Would you like me to do this? At the start of the scan, I will be taking some measurements, which can be sometimes difficult to get. To help my concentration, I will be silent for a few minutes while I focus on the monitor. Please don't let my silence worry you. This is a standard part of scanning. Something else you can say? Sometimes I'm not able to see everything I need to when using the probe on your abdomen. If this happens, I can do an internal scan, which can provide clear images during early pregnancy. However, it's your choice. If this is needed, we can discuss this then. So this is really brilliant because you're not only acknowledging them in everything that you've said here, but before we even start the scan, you've mentally prepared them for what to expect. And this will give you more time to really be able to get all the measurements you need. So the three things that you want to include in your conversation before the exam are that you might not see everything right away. You might have to do a TV scan. You might not be talking much, which is okay because you might be concentrating. And third, asking them if they would like the TV monitor off during the scan while you're concentrating. So now that you're all set up for the scan, what to do during the scan, how to go about this when you're expecting that you might have to deliver bad news. So although many times we might know within the first few seconds what you're seeing, sometimes we don't. We can't see things well enough. So what's important is that you don't want to start discussing your thought process before you even know what's going on. Before you say anything to them, please be 100% sure. This is because anything that you say to the patient, they will have in their mind for the rest of their life when they think about how the news was delivered. So what's important is that you don't want to rush. If you're unsure, we have the option of performing a TV scan with consent. So here's what you can say. I cannot see the baby on the abdominal scan. This could be because abdominal scans are not very clear when baby is in the early part of development. I would like to do an internal scan, which should give a clear view. Is this okay? Notice how they are always putting this in here because they want us to take consent during every part of the scan. But what do you do if you were trying to take your time to look at everything? But many times we have patients who've had multiple miscarriages in the past, and within the first couple of minutes, they already know that they've had a miscarriage. And often you end up telling them the news before you really wanted to, and now you don't have all your images. Now, bear in mind, you always need to take all of your measurements that you would normally take before you send them to the hospital. That's our duty of care as sonographers. If not, we're not doing this, if not as much, we're doing more than what we would be doing. So you'd be looking at anything and everything that would provide the hospital more information, which would be looking at things like a subchorionic hematoma, the location of the sac, and other things like that, and the environment and free fluid and things like that. So if you don't have all the images that you need, here's something you can say. Before I continue, I need to check, do you consent to proceeding with the scan? I like to check at this point, do you want to continue with the scan? So this is really important for you to know, for them to know that there are still more images that you need to take. The report would be incomplete without this, and you need their consent to proceed with the rest of the exam. And if they do not give you consent, that needs to be reported in our report. So the hospital or wherever we refer them to, they understand why we are sending an incomplete report. So what I usually try to do is take multiple clips and images. So if I need to, I can go back and I can remeasure and document things after if needed. Now, after the transvaginal scan, it's really important that we take the transvaginal probe out before we give them any news. You can imagine how uncomfortable it would be for a female to often have her bottom propped up and lifted in the air, her partner in the room, sometimes a child in the room, and she's hearing this unexpected news that is traumatizing, and she will remember this for the rest of her life. You do not also want to have a transvaginal probe inside her body. So please take the probe out before you give her the results. Ask her if she would like to get dressed before hearing the results. She might not want to wait, but you can ask. Here's what you can say. I've seen something that I'm not expecting to see at this stage of pregnancy. Would you prefer to talk about this now while I can show you the screen? Or would you prefer to get dressed and then we can talk? So again, you are asking them for their preference. We are never assuming what their preference is. Okay, now sometimes they have a child in the room. Sometimes they have more family members in the room. So we do not want to assume that they are comfortable having that child in the room when you give them unexpected results. So again, take the transvaginal probe out, ask them if they would like to get dressed or not. And before you give them the results, here's something you can say. I have found something unexpected on the scan. Would you prefer me to share this with you now? Or would you prefer your partner to wait outside with your son or daughter while I talk with you about this? A couple of things to notice here, Notice how they always use the term unexpected here. So we'll talk about why they do this a bit later. But the important thing here is that you are always getting their consent and getting an idea of how the patient in front of you would like to hear the news. We are not assuming that the way we want to give them the news is the best way. We want to gauge that. So the takeaway message here is you don't want to say anything unless you're 100% sure. Do not feel like you need to respond right away. If you're unsure, please take as much time as you need to do the scan. And we've discussed how you can do this by preparing them for the scan. And if it's not absolutely clear that there's no heartbeat, again, please do not give them any negative news. First, perform a transvaginal scan, and then you can discuss the findings with them. All right. So after you've done the scan, now you're prepared to discuss the findings. Now, before we talk about what to do during a miscarriage, let's address uncertain findings. So sometimes you're not sure because it could be PUL or it could be too early to visualize a fetal pole. So in this case, what they suggest is that we discuss all the possibilities, explain it to them in lay terms, and then we give them the most likely possibilities, also in lay terms, if you know the most likely possibility. Here's something you can say. There are 3 possibilities. I think the most likely is this, or I have not been able to see your pregnancy on today's scan. We know that you are or have been pregnant as you have had a positive pregnancy test. We call these pregnancies of unknown location. There are 3 possible outcomes here. Number 1 is that the pregnancy is very early and too small to see on the scan. Number 2 is that the bleeding that you've had is possibly been because of a miscarriage. Number 3 is that you have an ectopic pregnancy that I haven't been able to see. An ectopic pregnancy is where the baby is growing outside the uterus. Now, this is common in early pregnancy, and we will need to do some tests to help us work out which one of these outcomes we are dealing with. And often they will be sent to the hospital or GP to do these beta-HCG tests. What if they need a rescan? You can say something like this. I'm sorry. I know this probably wasn't what you were expecting to hear today, and this must be upsetting. I wish I could give you more information, but this is all the ultrasound can tell us at the moment. I will book you in for a follow-up scan in 2 weeks. At this scan, we will be able to tell you more about how your baby is developing. Now, this is such a brilliant way of communicating uncertainty. Notice how they first start with acknowledging how the patient is feeling. That, yes, I know you weren't expecting to hear this. I know you must be upset. I wish I could give you more information. So you are reaffirming that you are on the same page. You're showing them that empathy and you're showing them that you care. And then it's not taking it back onto you. Please don't say, I cannot see anything at this point, because it's not you, it's the ultrasound. So what we would say is the ultrasound cannot tell us anything more at the moment. And by next time, we will be able to tell you more. So notice the language that they have used here and really try to incorporate this in your day-to-day clinical work. Now, what do we do if there are certain findings that are worrying? And that would be in the case of a miscarriage. Before we talk about what the guidelines say in terms of the language you should use, which words you should use, what they've suggested is probably even more important is nonverbal communication. And I'm sure you've heard that. Communication is made of 2 parts, the words we used, and then the nonverbal communication, which some have said is 90% of our overall communication is nonverbal. So this is key. Now, when sonographers are asked how you should deliver news, they would mostly all say it should be, with empathy and compassion and kindness. But we all have different ways of showing this, and we all have a different idea in our head of what empathy looks like. So let's see what they have suggested here. So tone of voice is very important. You could be saying, all the right things, but your tone of voice could be completely off, and the patient could feel that you are being insensitive. So this is something that might come naturally to some of us, and for others, we might need to hear ourselves speak, or we might need to take into account patient feedback that we often get. So you want to deliver the news in an empathetic and compassionate tone of voice. I could say something like, I don't hear or see a heartbeat today, and I'm afraid I don't have good news to give you. Or I could say, I'm so sorry, I am not seeing what I was expecting to see. Now, you can see that I'm bringing my voice to a lower, softer pitch. And you want to do that when talking to patients, especially about this. When you engage with them, your engagement should be authentic and respectful. What do we mean by authentic? So this is directly a quote from a patient who went through this, and this is in a qualitative study done by Brown and al. Quite recently. They went to a bunch of patients who had experienced miscarriage, and they asked them what they felt about how their news was delivered to them. So this patient says, don't act like robots, act like a human. Act as if it was said to your wife or your daughter or your granddaughter. Think of if you had to talk to them in that sort of way. So this is really, really important, because if you had your relative, you wouldn't be saying things like, I don't think there's a heartbeat here. You would not be talking to them in this mechanical, robotic way. You want to act like a human. Now, this might seem really obvious, but I think as clinicians, we all tend to have, over time, we do develop a mechanical way of speaking at times. So we want to be wary of that. All right. The second part here is body language. And this is very important because, again, you might be saying everything right, but what you're doing with your body is going to communicate a lot. First, you want to give your full attention to the patient when delivering the news. Please do not be multitasking, like typing your report while talking to them, cleaning, or looking at their previous notes while talking to them, or making notes. This devalues the experience. If you do all kinds of things around them, you can imagine that they would feel that you're not really interested in giving them the news. You would not be doing this to your family member, would you? So let's not do this for our patients. You also want to sit at their eye level, and you want to make eye contact with them. Now, you don't want to be standing up and looking down on them. That's something really important. You don't want to come across like you're talking from a place of authority. You really want to build that rapport with them before, during the scan, and then be at the same level and communicate with kindness. So here are a couple of things that patients have said. When you're giving somebody bad news, set it aside. You don't need to be looking at my chart and just having a conversation one-on-one like that. This is directly out of a patient's mouth, and you can see that they notice these little things that you're doing while talking to them. Another patient, I think communicating that empathy through body language and tone of voice is probably the most important. So again, they are watching you, they're watching your body language, and it really, even if you end up saying something that wasn't 100% right, if your body language and tone of voice are empathetic, they will remember that, and it'll make a world of a difference. What else can you do? You can create a safe space for them to process those emotions. So it's important to understand that you don't want to overwhelm them by giving them a ton of information as soon as you did not see a heartbeat. They need time to process everything. So you might want to ask them, would you like a moment to process this information? Sometimes you might want to offer them some water if possible, if the clinic has that. So if there's a couple that are together, often it's okay to leave them alone because they have each other and they'll be hugging each other many times. So you can give them a moment, maybe ask them if they'd like some water. If a lady's by herself, it's important that you don't assume that she wants to be left alone. Some patients don't want you to leave them alone at that point because they feel vulnerable. So they might want you to stay in the room with them. So please ask them what they would like you to do. You can, if you are going outside to grab her some water, please tell her that she can take her time to process the emotions that she's going through now. And when you come back, she can ask any questions she might have, and we're just going to be outside the room. We won't be too far. The next thing here is silence. You do not want to try and overwhelm them with information right away and fill that silence. And this is something that I think a lot of us, just as human beings, are uncomfortable with. When there's silence, we get awkward. That's why they call it awkward silence. And we try to fill it by talking more. But this is going to overwhelm them even more, and it won't give them that space to process what they're feeling. So sometimes you just want to sit with them and not say anything, give them a few moments as they process everything, just allowing them to feel that you are there if they need to ask you questions. Okay. And in this entire process, please do not try to rush them. When you're giving them space, you can again let them know you're outside, they can take their time, and you'll answer any questions that they might have. So here's something a patient said. She was kind of more actively present, so she just kept offering these opportunities for the mom to express what she was thinking or feeling. She didn't try to fill a lot of space with talking. She just kind of waited to see what the mom had to say. So when she's saying the mom, she's talking about the patient here. So this was an experience that was a good experience, and notice that she said that she was actively present. The sonographer was actively present and she did not try to fill the space with talking. Again, this can make a world of a difference. Now, different patients can respond in different ways. What are the different types of reactions you might get from a patient when they hear this news? Well, you want to pay attention to understand what type of reaction they're having and then respond accordingly. Please remember that every patient is unique and there is no right or wrong way to accept unexpected news. So pay attention to not just what they're saying, you want to pay attention to the verbal and non-verbal cues shown by the patient. Here is a list of things. So some ways in which they might respond are they might cry. So they might be hugging their partner, crying in front of you. I think this is one of the most common responses. Second is they might be in shock. So if they're silent, please don't assume that they're okay and they're completely fine with the news. They might actually be in shock. They might really not be okay. They might be focusing internally on their thoughts. And different personality types will process emotions differently. Somebody else might be overwhelmed. So they might keep repeating the same question again and again, and they might be the one talking a lot to you to fill the silence. And again, in this scenario, you also want to be very patient with them. Somebody else might feel embarrassment. They might be too embarrassed to cry in front of you, and they might try to look away from you. They might try to get out of the situation as soon as possible. So again, you need to gauge that, and you would want to vary your scan time accordingly. Somebody else might be in denial. So they might be trying to resist the emotional distress that is coming with digesting this information. Someone else might get angry, so they might start getting upset with their partner. They might start raising their voice. Another patient might react in a manner of disbelief. So they might keep asking you, are you sure? Are you sure? Are you sure? And they might start repeating the same question. The important thing, no matter what their response is, is for you to maintain an open and empathetic body language and a tone of compassion, even if they're angry, even if they're in denial, and even if they're asking you too many questions, even if they're silent. You want to remain compassionate and show with your body language that you are showing empathy. So this is something you can do before you even start talking. Things that, you don't even need to think about your language at this point. But what about the verbal communication? What about the language that we use? Now, there's quite a few things here, and you might find that some of these things are in fact new for you. So the use of language. Many of us tend to use the word common and tend to remind the patient how common this experience is. Do you think that's the most appropriate thing to do? This is what one patient said. She said that discussing how common a miscarriage is devalues the experience for the patient. Another patient said, it's common discourse to me is said as a way to getting over this difficult piece of having to communicate this awful news and just get on with the next thing. To say it's common is for me not a way of empathizing with the person who may be distraught in front of you. So as a sonographer, you might think that you're doing them a favor by telling them how many of these scans you've seen and how many miscarriages you see all the time. This is not the time to tell them that you have 20 years of experience or however many years of experience and you've seen thousands of miscarriage. It's just like if somebody had their relative die, you would not go to their house and say, well, there's millions of people that die every day. So, it's the same thing here. Yes, it's common, but you don't want to devalue their experience because it's not common for them. It's a very traumatic experience for them, and you want to show that in the way you communicate. Now, this was something very interesting. So again, this is from the UK Consensus Guidelines for Delivering Unexpected News, and I'll give you the link at the end. But they talk about neutrality. What does that mean? What they're saying is that it's very natural to project our own values on the nature of information we're giving. We often might label something as good news or bad news. But what they're saying is we don't want to use certain phrases. They're saying don't use phrases like bad news or good news. Don't use words like normal or abnormal to describe findings. Instead, what we want to use are words like neutral phrases such as expected or unexpected. So you'll see in a lot of their guidance, they're not saying, I'm afraid I have bad news. They're saying, I have unexpected news. So this is really important and might be new for a lot of us because this guideline is very recent. They're also saying use the word chance rather than risk, because the word risk has some negative connotations, and then this is consistent with the Public Health England leaflets as well. So we want to remain neutral and not project our own values on the patient experience. This is another debate here. So what should we call the fetus or the baby or embryo? What do we say? Do we say I don't see a heartbeat in the fetal pool? Do we say baby? There's a debate about this, but the current consensus within literature and Public Health England is that most patients prefer the use of the term baby. It makes that experience a bit more personal to them. But what they've suggested is that we listen to the patient describe their own pregnancy. So if the patient is using other terms such as fetus or pregnancy, then you want to use the terms that they prefer and they feel comfortable with. So again, use the word baby if possible, but that doesn't apply in all scenarios. So you have to see what the patient preferences are. All right. Explaining your findings. So what exactly do you say? This is what they've suggested. At this stage of pregnancy, I would expect to see that the baby has a heartbeat. At the moment, I can't see any sign of a heartbeat. It's possible that it may be too early to see the heartbeat today, and we may be able to see this in the next week, but there's also a chance that this means the baby will not develop as expected, and you might experience a miscarriage. So notice what they've suggested is that they say, at this stage of pregnancy, I would expect to see this, but I don't see this. They're not saying things like good news, bad news, normal or abnormal. So that's quite important when we're thinking about the language that we're using. Here's something else. Please do not use a ton of medical jargon. It's going to overwhelm them. Please do not use the word abortion. I don't think most sonographers nowadays use it, but a lot of old school sonographers might say you're experiencing abortion. That is not appropriate because they don't understand what that means. Most of them don't. You don't want to use the term normal, abnormal, or disorder. Instead, what they've suggested is use the term expected, not expected, or you can use the term condition instead of disorder, because again, disorder has more of a negative connotation. All right. Here's something else they've suggested. Make no assumptions. Now, this is really important because I think as human beings, we try to give them news in a way that we might expect to receive. So a lot of us, what we'll do is we'll say, well, if I was in this place, this is how I would like to receive the news. That's an assumption. So things you don't want to assume is that they want to try again, or they would be happy to try again. So some sonographers will say, oh, well, I can give them hope and they might want to try again in a month or 2 months. And I can say that. That's an assumption. You don't want to go there. Please hold an open mind while delivering news. So be aware that patient might not view the news in a positive or negative way. They might not view this news in a way that you expect them to. So if 10 people before them have heard the same news and for them it was positive or negative, it doesn't mean it's the same for this particular patient or couple in front of you. So again, you don't want to say things like, oh, you can try again next month, it'll be fine, or, oh yes, like this is really bad news, it must be horrible for you, and I understand what you're going. You don't want to make these kind of assumptions. You want to have a very open mind. What else have they suggested? Sometimes patients might not believe you. So here's an example. Expected parent might say, I don't believe you, check again. You're just not doing it right. I don't believe you. So please don't feel like this is a personal attack on you. Please don't feel like you need to now talk about your qualifications and tell them how experienced you are as a sonographer. Notice what they say. I'm so sorry. I know this must be shocking and really hard to take in. I wish things were different, but I'm afraid this is what I have found. So sometimes it's not what they're saying, it's how they're saying it. When they say, I don't believe you, what they're really saying is that they're in shock and it's not easy for them to take this experience in. And this is why you want to acknowledge what the patient is experiencing and remind them that this is what's been found today, but say it in a very empathetic tone. Again, acknowledge, and reaffirm their emotions is what these new guidelines are telling us. Here's a couple of other really brilliant sentences you can use. I know this news is shocking and it must be so sad to hear. I wish I had different or better news for you. I'm so sorry that I don't. I know this news is really unexpected, not what you thought you would hear today, and maybe hard to process. Now, how well worded is this language? We're not saying things like bad news, we're not saying things like normal or abnormal, and we are reaffirming their emotions. We're saying, yes, this is shocking. I wish I had something else for you. So you're in it with them and you understand their pain, and you're sorry that you couldn't give them better news. And these are all ways of showing kindness and empathy. Okay, so the takeaway message here with all of this is that although we have these guidelines, each patient will respond differently, and your communication style should adapt to each patient. So we talked about all the different kinds of responses they had, and we talked about the language you can use, but in the end, you need to tailor the news to each patient. All right, so now that you've given them the news, what are the next steps? Remember to involve the partner. So many of us will only talk to the patient and ignore the partner. Keep in mind, if they're there as a couple, this is a difficult news for both of them. So here are their suggestions now. They say, this news must be unexpected for both of you and must feel like a lot to take in. What questions do you have? I will do my best to answer them. Okay, so important to say this news is unexpected for both of you. Next, unexpected pregnancy news can be really difficult for both partners. Do you have any questions I can answer, or would you prefer a few minutes to take it in? Again, acknowledging that unexpected pregnancy news can be really difficult for both partners. So we're using the term unexpected and we're involving the partner. Then you want to answer their questions. So ask them, do you have any questions for me? Is there anything I can answer for you? Bear in mind, this is after they've already had that initial time to process and digest the information. We don't want to do this right away. And please do not get frustrated if they ask you the same question again and again. Sometimes that is just a part of their normal response. Arranging further management. So bear in mind, once the patient hears unexpected news, they might not hear anything else after you say that. So you want to check back with them to make sure that they have understood what the next steps are. Make sure that they get a printed report with the next step, so they have a physical copy of the report in their hand. And let them know that you will be giving them some information about what happens next. And you'll be giving them a printed report. So if they don't remember anything that you're saying while you're talking to them, it's okay. They can always refer back to the report. So sometimes they'll say, where do I go? What did you say? Just remind them, this is where you go, but don't worry, if you don't remember, it's all going to be in your report. And I'll be giving you some extra information that'll help you more. Okay. Next, you contact their healthcare provider, which could be their early pregnancy unit, or it could be their midwife. We want to at least attempt to contact their healthcare provider to the best of our ability, because they might not be in a position where they can really even discuss what's happened during the scan. And you are in the best position to have that discussion, if it's possible. And the last thing, remember to breathe. Self-care for you as a sonographer is very important. It is not easy to deliver bad news. There have been many times that a lot of us have left our clinic and we have cried on our way home. We have cried when we've gone home, and it is very upsetting to deliver this kind of news. So it never gets easy. Give yourself some time as well, and breathe and take some time for self-care. And this is also something that they have emphasized in the guidance for sonographers. All right. So where can you find more information, and where did all this information come from? So these are my references. There's something called the ASCKS framework, which this entire presentation is based on. And we've covered all of this today, which is avoid assumptions, set up the scan, have clear, honest information, show kindness, and have self-care. care. The UK consensus guidelines for the delivery of unexpected news in obstetric ultrasound has this document, which they have called INDIRA, which stands for Improving News Delivery in Ultrasound. So this document called INDIRA is, the link is given here on this slide, and I'll be happy to send that to anyone who needs it. And the patient experiences that we discussed today were from Brand Study, which is linked over here, and the reference is over here. All right, well, I hope this presentation was helpful, and I hope this will improve the way that we as sonographers deliver unexpected news. What I would like you to think about after this, as I guess your takeaway, is I would like you to think about an experience that you had where you had to deliver unexpected news. Think about something that is vivid in your memory. And now that you've gone through this presentation, this webinar, think about what you did right and what you wish you would have done. So something that you could have improved. So this is a piece of self-reflection. Think about a time where you had an experience where you had to give unexpected news. What did you do that you felt was done well? What could you improve for the next time? All right, well, thank you everyone for joining in this webinar.